Yes. All right, great. Thank you.
Cool. Sorry about that. Okay, so I can start over?
I guess.
Okay, yeah, that's no problem. All right, so I'm Fotini. You guys, if you already know me, I'm one of the PAs working on the CAP interventional card service. We do all the TAVR stuff for inside the hospital and across the street. We take care of TAVR patients on our service, and then we also do consult and take care of TAVR patients on other services. And that's just kind of a little bit about me. What is TAVR? It's a transcatheter aortic valve replacement, and this is not the only valve that we do this way. We also do the other 3 valves in the heart. The TAVR program started at Penn in 2007. Dr. Herman is the attending who actually started the program here. We do about 600 cases annually here at Penn. A little bit about aortic stenosis. So you will most commonly see aortic stenosis treated with TAVR. Aortic regurgitation is not something that we typically, it's not a disease process that is best served with TAVR. So you don't really see a TAVR procedure done on those patients. It's mostly for the stenosis type. These are the 4 types of aortic stenosis. The most common is degenerative. This is most common in your 70 and above year old patient population. It's thickening of the valve leaflets. And then you have your rheumatic aortic stenosis. This is more common in your patients between the 40 and 60 year age range. And then you have the bicuspid aortic stenosis, which is an abnormality where patients have 2 leaflets instead of 3. 3 is the normal amount of leaflets. And then unicuspid, which we typically do not see or treat here. So there are 2 teams essentially who deem a TAVR patient appropriate for TAVR. It's the CT surgery team along with interventional cardiology. So typically, both of these teams kind of get together, they review the patient, they review the echo, they review the imaging, and they make sure that we're serving the patient best by giving them a TAVR instead of an open heart surgery, which may be better for them, just depending on what's going on. Who actually performs the procedure? It is the interventional cardiologist. A lot of patients get confused about this. A lot of patients commonly ask me the next day, oh, you know, that surgeon was so good, and they're either referring to like Dr. Grimm or Dr. Edluri, but they're not really the ones doing the procedure. They are involved and they are present in the OR, and that is in case they need to open up the chest emergently if they have a complication during the procedure itself. Some of the most important components of deeming a patient appropriate for TAVR is number 1, making sure that they actually have aortic stenosis and what type they have. We also get imaging, angiograms of the chest, the abdomen, the pelvis, and this is done for multiple reasons, but first and foremost is to make sure that the patient is anatomically appropriate for a TAVR valve. Sometimes the way that the blood vessels, the way that the coronaries are positioned and the way that the aorta is positioned and the way that the actual valve is positioned, sometimes they're too close together. The structures are too close together, which would deem patient inappropriate for this procedure, and they would have to go and get surgery. I mean, we've had patients who were turned down for TAVR that are in their 80s and they're going for surgery because we can't offer them TAVR because of anatomy issues. And then also it is to determine how we're going to get to the valve. So the rest of the blood vessels, do they have enough room for us to go through the femoral arteries? Are they best served with an axillary approach, a transapical approach? There's different ways that we get to the valve using different blood vessels. So a CAT scan really will help us kind of see where it's safest. Sometimes blood vessels are tortuous, so that's the purpose of that. And then the third is to actually measure the valve itself, because we have different types of valves and they all come in different sizes, and we use a CAT scan for measurements to see what is most appropriate. And then another part of the workup is getting a left and right cardiac cath to see if they have anything else going on that needs to be treated before or after TAVR. Is their volume status appropriate for TAVR? Do we need to diurese them another week and then approach them with the TAVR? Do they have any coronary blockages that need to be treated before? Can they wait until after? Things of that sort. And then there's a bunch of other stuff, but these are the three most important things that to choose. And then, of course, if any of these things disqualify the patient for a TAVR procedure, then they go to open heart surgery if they're appropriate. These are, oops, sorry. These are the different types of valves that we have. We have the Evolut family and the Sapien family. So depending on what size the patient needs, that's how we kind of determine which valve we're going to use. The Evolut is a self-expanding valve. So once they pop it into place, it kind of fits itself into the space. And it could take up to a couple of days, maybe even a week for it to fully expand to the patient's size. And then the Sapien is already kind of a predetermined size. It's blown up into position using a balloon. And then after it's blown up, there's no way that you can take it down or reposition it or do anything with it. Some points of access. So the most common points of access that you'll see are the groin, so the common femoral artery, the left and the right. All your TAVR patients will have two femoral sticks on the left and the right. This is the most common. Sometimes we do have to switch it up depending on their blood vessels. If they have tortuous arteries, then we cannot use one side, so we use, things can change, but the most common type of patient you'll see is with this presentation. So you'll always have two sides, two femoral arteries accessed, one on the left, one on the right. One side will always be bigger because the valve will go in through one side, and then the other side is used for a regular like cardiac cath. So your patient's going to the cath lab, so that's the size that they use for the opposite side. And then you'll always have one venous stick. So it could be on the right, it could be on either side. So these are pretty much your points.
I heard you can go today. I only need to talk to.
And then you have your radial arteries. So one side is going to be used for an arterial line, which anesthesia uses during the case, and then the other side is used for a sentinel device, which is pretty much a little device that they deploy in the carotids. It looks like a condom sitting in the carotids, and what it does is it's like a little umbrella condom, and it catches any blood clots that kind of break off from the aorta and travel up towards the brain. So that's pretty cool. Not every single patient gets the sentinel device. It just depends on what's going on with the radial arteries. If they have spasm or if they have tortuous arteries, they can't do this. But majority of the patients come out with it, and they have TR bands there, which are probably deflated by the time they come up to this floor. That later. So the two most common complications that we really drive into the TAVR patients when they're undergoing evaluation is that they have a chance of developing an arrhythmia during and after the TAVR, and sometimes also having a stroke. The stroke that can occur typically happens almost immediately, and the further away that we are from the procedure itself, that the chance decreases. So if we make it through the first 12 hours, I think we're pretty solid, and then the first 24 hours is even better. And then the arrhythmias is the reason why we keep patients in-house for 2 days. And these changes can occur even up to day 3. Sometimes we keep patients even longer. So kind of key points for you guys to know for the arrhythmias is to notify the provider if there are any telemetry changes or vital sign changes. So if you notice that the QR complex is widening, or if there's PR prolongation, these are the types of, things that you should, if you have any concern at all, you can reach out to the provider. But the best thing you can do is probably grab an EKG. If you have any sort of concern, getting an EKG right when it's occurring and then calling the provider is probably the best bet, even if it's a false alarm. And then for the strokes, the key point here is to kind of get to know what the patient's baseline is. You can, of course, always reach out to the provider and we can have a discussion about it. Or if there's family at bedside, you can certainly ask the family. And then you also have to assess your patient. Is this somebody who, are you concerned about something in a patient who doesn't memorize their medicines or doesn't remember the days of the week? Because even though patients don't remember these small things, it doesn't mean that they're far off from their baseline. So it's pretty much trying to do the best you can to get a feel for what the patient's baseline is. And then some other differential diagnoses when they do have things surrounding mental status changes to really consider our anesthesia related confusion and amnesia. We've had patients wake up from anesthesia and not remember where they are, who they are, and this has lasted for a few hours. Doesn't necessarily mean they're having a stroke, but it is common in anesthesia. Are they having hospital delirium? Of course, we don't see this right away or in the first day, but patients certainly develop this after being here a few days, especially if they have complications. And then over sedation, sometimes patients take a while to wake up from their anesthesia. I've had a patient take an hour to kind of come to his or her senses before they can even answer questions. But on our neuro exam, they're examining correctly, but they're not really speaking or verbalizing. But again, once these patients come up to this floor, they should be able to speak and answer your questions. So we would never bring a patient out of the cardiac recovery if they're not speaking to us and if they're not mentating or if there's even a concern that there's something different. And then just something to slightly mention is that that the mental status changes are also a gray area for some of the providers too. Because our attendings we have 5 different attendings who do TAVRs and they all have different approaches on patients with mental status changes. Ultimately though, you kind of always have to reach out to the provider and allow us to appropriately triage these patients and kind of come up with the next step on how we're going to treat them appropriately. And that is always getting the attending involved and kind of coming up with a plan together. Some other post-op complications that are very common. So we spoke about stroke and arrhythmia, but we also have other things that can happen. Hypotension is very, very common, and this can happen for a matter of reasons. I have listed out the kind of the most common reasons why they happen, and then some of what we less likely see are pericardial effusions and myocardial infarcts, but a lot of it is related to anesthesia. A lot of it is related to the remodeling that happens to the left ventricle during the time frame that patients have severe aortic stenosis, and now all of a sudden their valve is fixed, and so the left ventricle is kind of confused and it doesn't know what to do. And so in these patients, we do see low blood pressures, and then they can also have blood loss. The sheets that are used for the valve are 14 French. So I've kind of used this little picture here to kind of put things into perspective. That's a 12 French, but if you can imagine a 14 French, it's slightly bigger. So these are pretty big sheets that are going in. So you can expect some blood loss. Afterwards, we always expect about a 1 to 2 point drop in hemoglobin, just because the stick is so big and we do bleed a little bit intraoperatively. And then the side that the valve doesn't go into your regular catheter side, it's a 6 or 7 French, depending on the artery or if it's the vein. That side doesn't usually bleed much, but just for your knowledge. There can be vessel damage. There's a lot of instrumenting and moving things around in that area. So hematomas, pseudoaneurysms, we see these commonly after this procedure if there is a complication. And then they can have ongoing access site bleeding. The surface of the skin definitely has a pretty large slit. This is not sutured, it's not glued. I don't think we're there yet. And so they can have a lot of superficial bleeding that we deal with ongoing. So hypotension and what we do. So in our regular EF patients, our MAP is always above 65. So if you have a patient below 65, that's unusual. If you have a patient with a low EF, that threshold kind of lowers a little bit. We use arterial lines and cuff pressures to kind of treat this. And our go-to are neo drips. They're very floor step down friendly. We use a lot of fluid resuscitation depending on if we can, depending on the situation. And then we do a lot of other monitoring with EKGs, ABGs for that really quick hemoglobin change if they are bleeding. Physical exam, if they are bleeding into the groins, we rely on a physical exam. Some red flags for you if you do get a patient up here with an arterial line and the cuff pressure. The arterial lines, we always leave them in patients longer if anesthesia has to use any type of pressor during the OR. Some patients can take a very long time to wean off of these, sometimes 24, sometimes 48 hours. So that's why you see these patients coming in with arterial lines. If they do absolutely perfect in the OR, we remove the arterial lines while they're in the cardiac recovery. We don't like them to come up here with it. But if you do get a patient with an arterial line, it's because something happened. So a red flag is if you are finding that you're going up on the drip rates, that's a phone call to the provider. And if you find that your hypotension is coinciding with your bradycardia, that's also a phone call to the provider. Those are huge red flags. Some access site complications are hematomas and pseudoaneurysms. So the first thing to do if you do have a concern for these, what you'll typically see first is swelling, or the patient will complain of pain. You'll notice one side is more swollen than the other, or both sides are swollen. You'll notice lumps. So the first thing to do is to take the bandage off and actually see if your site is bleeding. If it's not bleeding, but you notice a lump or swelling, you have to hold pressure immediately and then get somebody to call the provider so we can come and assess the bedside. Another thing you can do is if you have help is have somebody come and check distal pulses. So some of the red flags again are swelling, pain out of proportion. This is also very abnormal, especially if you have vital signs that are correlating with pain, like elevated blood pressure, tachycardia. That's a big red flag. If you feel firmness under the stick, this is also a problem. That means blood is collecting there. It shouldn't be there. All access sites should be soft. They could be discolored, that's fine, but they have to be soft. If you lose distal pulses, huge red flag. If there's any change in color and temperature, or if a patient is complaining that their leg is numb, huge red flags. How do we treat these? If they're early on, we just continue to hold pressure until the site around the stick is soft. So a lot of pressure, we do a lot of massaging. If we have to massage a hematoma on a patient, this can turn into a rapid response because they typically have vasovagal episodes with this. So if that's something that we're going to do, we will let you know because you may need help to bring things to the bedside. We extend bed rest. We use things like IV bags, sandbags, if they're available, to continue to hold compression, especially if it's early on after the procedure. We do get the fellows and the attendings involved. These are complications that can typically get out of hand if they're not caught pretty early. We consider imaging, and then they may need to go back to the OR for some vascular intervention. And then the long-term outcome of this treatment, it will affect on what we use for antiplatelet and anticoagulation for these patients if they need it. We use closure devices after TAVR. So if you hear the term PER closure, this is a device. The ProGlide is what we have here at Penn. These are other devices that they use at different hospitals, but the ProGlide is what we have here. I have a cute little video to show you how this works.
I don't think they're seeing this. Give the switch how you're sharing. So stop and then switch to the window. Yeah.
Window?
I think so. And then your video should be right there.
All right, perfect. So this is a little suture. So it's a little stitch, but instead of the skin, it's actually used in the inside of the blood vessel. And if we're poking these really large holes into the patient's blood vessels, we have to close them somehow. This is just one way of closing it. And that's pretty much what the patients are left with. The side of the groin that gets the valve gets 2 of these because it's very large. And then the other side gets 1 of these, and these only go in arteries. Okay. So typically these patients stay for 2 nights if they are uncomplicated. Sometimes their stays can be longer if they do have complications. If they need pacemakers, they stay another day or 2, depending on if there's room for them to get a pacemaker on the EP schedule. If they have other complications, I mean, all sorts of things can happen. But typically it's a 2-night stay and everybody's very happy to go home on that 2nd day. These are some other transcatheter procedures that we do here. We do it with the mitral valve. Most of the time when there's already a valve there, we use one of the TAVR valves to replace the mitral valve. The tricuspid valve, you guys might see this. You may have seen this recently. Dr. Herman just did one. He's going to go home today or tomorrow. The pulmonic valves are kind of less common. Paul Fear really does those. No other attending really does those. Those are mostly for the congenital patients who've already had some form of surgery. All of these are done through the femoral vein, so there are no artery sticks here for the valve itself. And these are pretty massive sticks. I mean, they could go up to 45 French depending on the different valves. Different hospitals use different valves, and so depending on what valve, that's how big the stick is going to be. But the gentleman that we have currently on our service, I think, got a 33 French, so it's pretty big. He restarted his blood thinner and he bled the next day. So this is